Hello everyone. Welcome to another episode of Retina Roundup. I am Dr. Shweta, Fellow in Vitro Retina at Shankara Eye Hospital, Bangalore. So let's look into the top few articles of this month. The first article titled Central Serous Chorioretinopathy Imaging Biomarkers as Potential Indicators of Response to Subthreshold Nanosecond Laser. The purpose was to evaluate OCT and ICGA biomarkers in patients with chronic CSC as potential indicators of response to treatment with subthreshold nanosecond laser. In this retrospective study, 36 eyes of chronic CSC patients were examined after nanosecond laser. High response was defined as complete resolution of SRF 3 months after first sitting, full response as complete resolution of SRF 3 months after the last sitting, with all sessions occurring within 1 year from the first session. Biomarkers included central macular thickness (CMT), subfoveal choroidal thickness (SFCT), and interaortic venous anastomosis (IVA). OCT at baseline showed a mean CMT of 346 micrometers, SFCT 292 micrometers. High response was seen in 50% and full response in 78%. High interaortic venous anastomosis rates predicted poor response after the first nanosecond laser session, showed a statistically significant higher likelihood of requiring more than one nanosecond laser session. Conclusion was, OCT and ICGA biomarkers may play a role as indicators of anatomical responses to nanosecond laser. Patients with IVA at baseline showed a poor first response and may need repeated laser treatments. Let's move on to the other article. Delayed onset recurrent retinal detachment more than 1 year after pneumatic retinopathy, scleral buckle, or vitrectomy for primary rhegmatogenous retinal detachment repair. This was to evaluate the incidence, causes, and outcomes of recurrent rhegmatogenous retinal detachment occurring more than 12 months after the initial RRD repair. This retrospective case series examined patients who underwent primary pneumatic retinopathy, scleral buckle, pars plana vitrectomy, or combined PPV and SP for primary RRD and were followed for at least 12 months. Patients treated with silicone oil were excluded. The primary outcome was the incidence of delayed recurrent RRD. 3,668 eyes were included. The mean follow-up length was 4.9 years. 51 eyes from 51 patients developed delayed redetachment. The time to delayed redetachment was 3.8 years. The incidence was 4.4% after pneumatic retinopathy, 2.8% after scleral buckling, 0.9% after pars plana vitrectomy, and 0.6% after PPV plus SB. The causes of redetachment included new tears, proliferative vitreoretinopathy, and others. Reoperation resulted in anatomical success of 88.2% at 3 months and 98.9% at a final visit. Conclusion. Recurrence of RRD more than 12 months after initial surgery may occur in 1.4% of patients with a higher incidence after pneumatic retinopathy and lower incidence after pars plana vitrectomy and PPV plus SP. Reoperation resulted in acceptable anatomic outcomes. Let's go to the next article. Comparison of myopic maculopathy progression in patients with myopic traction maculopathy undergoing vitrectomy or macular buckling. Study compared the progression of myopic maculopathy in patients with stage 3 myopic traction maculopathy undergoing either pars plana vitrectomy or macular buckling. A total of 61 eyes were retrospectively divided into PPV group with 30 eyes and macular buckling group with 31 eyes. Best corrected visual acuity, axial length, and myopic maculopathy progression and retinal and choroidal thickness were measured and compared. The mean follow-up period was 70.9 months. Progression to a different stage occurred in 14 eyes in the PPV group compared with only 2 eyes in the macular buckling group. In total, 5 of 30 eyes in the PPV group and 2 of 31 eyes in the macular buckling group showed progression within the same MM stage. In addition, 9 eyes in the macular buckle group exhibited retinal pigment epithelial injury adjacent to the macular buckle ridge. Postoperatively, foveal retinal thickness and central choroidal thickness was significantly greater in the macular buckle group. For patients with stage 3 myopic traction maculopathy, PPV may accelerate the progression of myopic maculopathy, whereas the macular buckle may not. Therefore, macular buckle may be a preferable surgical option for these patients. Let's move on to the next article. Foveal configuration after amniotic membrane transplantation in complex macular holes. This study evaluated outcomes and foveolar morphological changes after human amniotic membrane transplantation in complex macular holes. A multi-center retrospective analysis was conducted on 30 eyes that underwent vitrectomy with human amniotic membrane transplantation for indications including failed prior macular hole closure, macular hole associated retinal detachment in high myopia, giant macular holes, and large macular holes, unsuitable for internal limiting membrane plaques. Postoperative assessments included closure rates, visual outcomes, and foveal structural changes on OCT at 1, 3, and 6 months. The study showed macular hole closure with retinal tissue reconstitution was observed in 73.3% of eyes at 1 month, whereas 23.3% showed foveolar dehiscence with exposed human amniotic membrane in the subretinal space. Visual acuity improved from logMAR 1.22 to 0.99 at 1 month, 0.98 at 3 months, and 0.97 at 6 months. The bare human amniotic membrane area decreased over time in eyes with foveolar dehiscence, and retinal tissue reconstitution was observed in 3 of these cases. A larger preoperative minimal linear diameter was significantly associated with this pattern. To conclude, human amniotic membrane transplantation demonstrated favorable outcome in complex macular holes, supporting its potential role in the anatomical restoration. The next article is titled Temporal Retinal Vessel Angle as a Biomarker for Familial Exudative Vitreoretinopathy. This study aims to investigate temporal retinal vessel angles measured from color fundus photographs as a biomarker for assessing clinical outcomes in familial exudative vitreoretinopathy. The primary objectives were to establish correlations between TVA and key clinical parameters, evaluate the predictive power of TVA for poor visual acuity and foveal hypoplasia, and determine optimal threshold angles for risk stratification. This retrospective case series included 65 patients. Ophthalmic examinations, imaging, and TV measurements were conducted. Statistical analysis included correlation coefficients, logistic regressions, and receiver operating characteristic curves. The results showed TVA exhibited negative correlations with key clinical outcomes, including BCVA. Logistic regression analysis revealed associations between narrower TVA and key outcomes such as poor BCVA and foveal hypoplasia. Receiver operating characteristic curves demonstrated area under curve values for predicting poor BCVA and foveal hypoplasia for temporal retinal artery and vein angle, respectively. Optimal threshold were determined, that is for temporal retinal artery angle 65.02 degree, temporal retinal vein angle as 72.87 degree. The conclusion was TVAs emerged as sensitive predictors of familial exudative vitreoretinopathy outcomes, showcasing robust correlations with disease severity and functional outcomes. It highlights TVA as a potential non-invasive biomarker for prognosis, aiding in early detection and facilitating timely interventions. Future research with larger cohorts and longitudinal follow-up is guaranteed to validate the utility of TVA in clinical practice. The next in the list is a surgical procedure, vitreous cavity lavage with a bended needle system for postoperative vitreous cavity hemorrhage. This retrospective case series included all patients with postoperative vitreous cavity hemorrhage who received vitreous cavity lavage with a bended needle drainage system from January 2022 to May 2024. Patients adopted a supine position that allows preparation and draping. BSS was injected with a 30 gauge needle. One bended 25 gauge needle was used to drain the blood. Primary outcomes include the visual acuity and short-term postoperative complications. Secondary outcomes include preoperative and postoperative intraocular pressure and long-term complications. 3 patients with postoperative vitreous cavity hemorrhage received the procedure, with 2 cases of proliferative diabetic retinopathy and with 1 case of primary central nervous system lymphoma. All patients recovered well after the procedure with minimal complications. Long-term prognosis largely depends on the primary retinal conditions. In conclusion, vitreous cavity lavage with a bended needle system is safe and effective to manage postoperative vitreous cavity hemorrhage with an outpatient surgery, which potentially benefits patients with similar conditions. The last one is a surgical technique too. Simplified technique for correcting intraocular lens decentration in scleral sutured fixation surgery. During surgery, Purkinje images were used to assess IOL positioning. A straightforward IOL decentration adjustment technique was used when necessary. Patients in whom IOL position were corrected and who were followed up for at least 3 months after surgery were included in the study. From June 2023 to February 2024, 6 patients with noticeable IOL decentration were successfully treated using this technique. After a mean follow-up of 3.17 months, there was a significant change in spherical error. While the BCVA, refractive cylinder, intraocular pressure, and corneal endothelium density remained unchanged. Importantly, the IOL was well centered in all six patients with average horizontal and vertical IOL decentration of 0.21 mm and 0.220 mm respectively. This simple IOL decentration correction technique demonstrated favorable results and may enhance IOL positioning in scleral fixation procedures. That's all for this month. See you next month with new set of articles.